Well, good afternoon, all. We're resuming our spinal cord injury lecture series after several weeks off. I guess first off, if somebody could just give me a thumbs up, you can hear me so that I know that we're going okay. Thank you very much. That's always a worry. You start into these things and you wonder if you're going to be heard. So today we're going to be talking about pain management after spinal cord injury. I'll be going through definitions of pain, and that'll include both nociceptive as well as neuropathic pain. Talk through the anatomical pathways and then the pathophysiology associated with spinal cord injury. We're going to spend just a little bit of time talking about the evolution of the taxonomy that's used to define pain syndromes in spinal cord injury, and then talk through some of the practical applications. I guess if nothing else, over the last 50 years, we've learned that nobody is immune from spinal cord injury and nobody is immune from pain. There, but for the grace of God, go I. And so I think it's important for us to recognize that this could happen to us individually, or it will happen to our patients. And so it's important that we understand mechanisms to the extent possible, and that we understand options for treatment strategies. So I know that in PM&R we spend an awful lot of time talking about pain. The definitions as provided by the International Association for the Study of Pain include just the general definition of pain, which is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Generally speaking, we divide pain into two major categories. One is nociceptive, in which pain transmission is provided along normal nerves to the CNS about trauma to tissues, typically non-neural tissues. And then neuropathic pain, which is that in which there are structural and or functional nervous system adaptations due to injury. And within the aspects of neuropathic pain, which by the way is where I'll spend most of my time today, since we just had a wonderful presentation on particularly nociceptive pain by Dr. Vivas Alvarado. So I'm really going to be focusing most of my time and attention today on neuropathic pain. So let's just, so that we're all speaking from the same page, go through these different definitions. Allodynia is pain due to a stimulus which does not normally, provoke pain. And so that's the type of a scenario that we will be discussing in more detail. Causalgia is a burning pain. It has both allodynia but hyperpathia, and it may include vasomotor and pseudomotor dysfunction, typically associated with a traumatic nerve lesion. Central pain is initiated within the central nervous system, so either the brain or the cord is where the primary lesion occurs. Dysesthesia is an unpleasant abnormal sensation, and it can be spontaneous or evoked. Hyperesthesia is increased sensitivity to stimulation, and this is one that excludes the special senses. So for example, photophobia or hypersensitivity to auditory stimulus doesn't fall into this particular category. Hyperpathic pain is a painful syndrome characterized by abnormal pain reactions to a stimulus. And so typically this is a repetitive type of stimulus that makes things worse and worse as it continues. Neuralgia is pain in the distribution of a nerve or nerves. And so that includes the dermatomes as well as the specifics. So for example, you could have ulnar distributed pain. And then paresthesias, this is an abnormal sensation, may be spontaneous or evoked, typically associated with numbness. And so these are the main types. And we're going to talk about diagnosis and, more importantly, the pathophysiology associated with them as we go through this. So as you all know, the central nervous system is comprised of the brain and the cord. We spend a lot of time talking about the somatic nervous system, so we can determine level of injury and the completeness of injury. Levels of injury are associated with specific dermatomes and myotomes, and those all fall within the somatic nervous system. We recognize as well the interplay of the autonomic nervous system and particularly its interaction with the central nervous system. Parasympathetic nerves can transmit sensory information that can be perceived as painful. But we also have sympathetic nervous system activity, and remember that originates within the thoracolumbar regions of the cord, and can also modify and or amplify painful stimulus as we talk through this. So the cellular components of the central nervous system, it's important to kind of step back for a moment and recognize what the central nervous system is comprised of. Nerve cells represent only 10%. What? Only 10% of the mass within the central nervous system are actually nerve cells that conduct electrical impulses. 90% of the cells within the central nervous system are in fact glial cells. That is, these cells support, nourish, or insulate, that is, protect neurons. These cells in and of themselves do not conduct nerve impulses. And so they vary between the oligodendrocytes within the central nervous system. Remember, provides the myelin that allows for saltatory conduction between the nodes, as we say. You have the astrocytes, and the astrocytes provide nutritive function between the vascular system and the nerve cells themselves. The ependymal cells line the central nervous system, and then microglia are essentially this scavenging cells, phagocytic cells within the central nervous system. Now, we'll talk briefly about Schwann cells, but very briefly, because they actually don't lie within the central nervous system under normal conditions. But they do provide in the peripheral nervous system the myelin sheaths, again, associated with saltatory conduction and the speed of conduction through the nervous system. So the neural tracts of the spinal cord. Remember that the cord is about the size of your little finger. This cartoon is very simplistic in that it shows on one side the motor tracts and on the other side the sensory tracts. But you know that the reality is that you have all of those tracts on both sides of the cord. And they are well insulated and productive. These are, I should say, protected tracts that run up and down the cord. And yet, recognize that conduction through the spinal cord is going to include these descending tracts, motor tracts, if you will, and those are being passed down typically from the brain and or cerebellum. The periphery, the peripheral nervous system, provides afferent information as well, so that you have afferent information ascending the cord. And yet, that information is coming in at about 1 centimeter intervals along those dermatomes that we've talked about. And so you have afferent information coming in. You also have efferent information going out, and there is some communication between the two because of interneurons that can either be facilitatory or inhibitory in nature. And so again, very simplistic cartoon, I get that, but just keep in mind then what happens if you damage the cord and interrupt the conduction of neural influences throughout the cord. Keeping in mind that we're going to spend most of our time today talking about the afferent side of this cartoon, recognizing that obviously it's available on both sides as we go through there. So these ascending tracts, these afferent conducting pathways, include spinothalamic, which provides light touch, pinprick, and temperature, spinal reticular, which provides information about deep pain, and then the dorsal columns, which provide information about proprioception, vibration, and light touch. We recognize that there is decussation of these pathways as afferent information comes in, it crosses at about 2 levels above where it enters, and then passes up on the contralateral side to the somatosensory cortex. You have position vibration information coming in, and it ascends ipsilaterally crosses over at the level of the medulla and provides information to the somatosensory cortex. Light touch, on the other hand, is redundant in that you see both the spinothalamic and posterior columns seem to convey the same information, some of which is crossed over at the level of the medulla. And then you have unconscious proprioception, which is conveyed along spinocerebellar pathways, and it goes up ipsilaterally. And then ultimately we have our motor pathways and recognize that those originate on one side of the body in the cortex, cross over at about the level of the medulla, and then pass down on the contralateral side. So pain pathways, recognize that there are lots of opportunities to be able to appreciate pain, to perceive pain because of the way the body is set up. There are redundant pathways. But the bottom line is you have afferent information coming in from, and it can be a chemical receptor, a mechanical receptor, or other types of sensory receptors that send information up through, goes through the dorsal root ganglion, and then synapses with these interneurons at different places within the cord. You have a number of different neurotransmitters that we can talk through, keeping in mind the primary afferents. Those are the ones coming from the periphery to the dorsal columns of the cord, convey three types of information, generally speaking. Non-nociceptive information is conducted along A beta fibers. This responds to low intensity, non-painful proprioceptive, so you have vibration and light touch stimulation, that is conducted fairly quickly along thick myelinated large diameter fibers. Then you have the A delta fibers that are providing the nociceptive pain, and these are providing information that conveys from localized sharp pain, and these also help with the pain withdrawal reflexes as we go through there. Again, these receptors can be thermal, mechanical, or chemical in nature. Moderately fast conducting and thinly myelinated moderate diameter afferent fibers as they bring information from the body to the cord. And then you have these C nociceptive fibers. These respond to various noxious stimuli, typically are transmitting poorly localized pain, slowly conducting. It's a dull pain. It can also be thermal, mechanical, or chemical in nature. But now these are unmyelinated small diameter fibers that convey information fairly slowly. Once the pain information gets to the cord, then it ascends dorsal columns to the thalamus and to the brainstem, into the reticular system, and the reticular activating system of the brain, and then to the tertiary afferents, where you take information from the thalamus to the somatosensory cortex, which is where you perceive pain. So a number of different neurotransmitters for pain. Along those primary afferents, you have glutamate and aspartate as the primary neurotransmitters. But these can be modulated by substance P, calcitonin gene-related peptide, VIP, vasoactive intestinal polypeptide, and NPY, neuropeptide Y. All of these can change how you're perceiving pain. By the time it gets to the cortex, these influences modify the way that you're perceiving pain. You have descending inputs with neurotransmitters, including glutamate, acetylcholine, serotonin, norepinephrine, and dopamine. These also can influence the activity of pain afferents, typically secondary and tertiary afferents as they ascend the cord. You have local circuit interneurons, again, with neurotransmitters including glutamate, aspartate, glycine, GABA, and acetylcholine. Also can be modified by somatostatin, substance P, and enkephalins, VIP, and NPY. And then you have non-specific targets. So most cells have these ion channels But some of these, so for example, the sodium voltage gates 1.7, these are particularly susceptible or provide conductivity for pain. And then you have second messengers that will also interact on these. Transsynaptic signals, including nitric oxide, carbon monoxide, and prostaglandins. You recognize the importance of trying to keep these in check to minimize the perception of painful stimuli, and then other factors that we'll just talk about briefly towards the end of this talk, the neurotrophins and the cannabinoids. So, pain, neuropathic pain in particular, involves a structural reorganization somewhere within the cord and or the thalamus. And so essentially, they've done research where they've done cordectomies and found that that hasn't been beneficial to folks in trying to stop neuropathic pain. They know that hyperactivity and spontaneous activity is noted in even deafferented models. What's up with that? There can be disinhibition or imbalance of these spinal pathways, and then a fair amount of intraspinal sprouting, where then you have communication that shouldn't be. And potentially there are blood-brain barrier and CSF abnormalities following a spinal cord injury. Neurochemical changes also include a number of excitatory amino acids that are released after spinal cord injury. So the glutamate pathways that we talked about will contribute to hyperexcitability or hypersensitivity to pain. Inflammatory products and then sympathetic influences can also mitigate pain as we consider that. So we talked about what happens within the spinal cord. Recognize that, why don't we just fix it? Why don't we just cure a spinal cord injury? Well, recognize that soon after the spinal cord injury, there is a significant amount of glial scarring. Remember, the glial cells comprise 90% of the total space within the central nervous system. And so that glial scar occurs in the 360 direction, that new neurons that would convey sensory information or motor information, they're going to have to break through this glial scar at both ends, fore and aft, if you will. But even if we were somehow to break through that, there's this chasm in between. And so, potentially we can put cells in there, and those can be Schwann cells or stem cells. We have scaffolding proteins that are being trialed in animal models as well. The bottom line is you need to have some sort of a scaffold or a structure for neurons to lay across as they're ascending and or descending in these new pathways that are being developed. But recognize that even if we put cells in there and we broke somehow through the glial scar, there are still a number of inhibitory proteins that are hostile to new neural cell development. And so, those include a number of different things, including the no-go proteins, the myelin-associated glycoproteins, tumor necrosis factor alpha, and nuclear factor kappa B, all of which are actually hostile to new neurons that are trying to develop in this quagmire, if you will. If somehow we could disinhibit these inhibitory proteins, get across the chasm by having a cell structure or scaffolding structure, break through the glial cells, we still need to have, for the appropriate development of these neural cells, specific growth factors. Nerve growth factors, brain-derived neurotrophic factor, BDNF, glial-derived neurotrophic factor, GDNF, fibroblast growth factors, and then cyclic AMP, all of which are required in specific concentrations at specific times in the neural cell's development. But even if we could put together a cocktail and provide those, we still haven't mastered one of the most important things, and that is, how do we direct the growth of these neurons? Because without it, we are likely to have miscommunications, and subsequently those would be developed as neuropathic pain, spasticity, and other types of pathophysiology. So recognize that there are a number of chemokines associated with neuropathic pain. And these can occur in the periphery as well as in the central nervous system. And so these chemokines, and we can look at the space between, I'll say, secondary afferent cells that are providing information up to the brain. If you have these chemokines, they can influence what is perceived by the secondary and tertiary afferents. And so then we have to talk about what are our treatment options for these. And we can look at non-pharmacological, and we will. We'll talk about some of the pharmacological strategies and then consider surgical options to manage particularly neuropathic pain. So the pain taxonomy, back before the turn of the century, Sedal put forward in Spinal Cord. Basically, this taxonomy, which looked at pain above the level of the injury, pain at the level of injury, and pain below the level of the injury, recognizing that that pain could be nociceptive or neuropathic in each of those categories. Tom Bryce and Chris Ragnarsson further reported up on this in a very nice article right around the turn of the century. In 2006, Sedal and Middleton upgraded their pain taxonomy, their definitions, and said, well, we should just call it nociceptive or neuropathic. Nociceptive could be musculoskeletal or visceral pain, or neuropathic above, at, or below the level of the injury. And then Tom Bryce and the International Spinal Cord Injury Group put together a more recent taxonomy in which they talk about tiers. And I know what you're thinking, no more tiers. But yes, tier 1, tier 2, and tier 3. Now, the tier 1 has to do with the pain type. Is it nociceptive, neuropathic, or other? Within the pain type, if it's nociceptive, is it musculoskeletal, visceral, or other? If it's neuropathic, is it at, below, or in the peripheral nervous system? And then tier 3 has to do with more specifics within the pain type. So is it glenohumeral osteoarthritis if it's nociceptive? If it's nociceptive, is it myocardial infarction or appendicitis from a visceral origin? If it's neuropathic at the spinal cord injury level, is that nerve root compression or damage? If it's below, is there something happening with regard to ischemia? Is there a tethered cord contributing to this? So this is the current classification system that we're all working with. Sedal and Middleton in 2006 put forward a treatment basically set of recipes that talks about assessing the system, that is, get the history, identifying the pain type, assessing the site history, identifying the pain subtype. I guess I forgot to highlight these as I go through them. But then talking through the structural components, identifying the pathophysiology, treating the cause, and then treating the symptoms as necessary as we go through there. So again, these are the components that Sedal and Middleton put forward in their 2006 article that are still very, very valid as we talk about pain management. So the system assessment, what does that mean? Is pain located in a region of normal sensation? If the answer is yes, then we know that that's nociceptive pain. But if it's no, then we start to move down the other pathway of neuropathic pain. We do a site assessment, and is this position dependent? Is it activity related or is somatic tenderness? Is it related to the viscera? Is it above, at, or below the level of the injury? So looking at the site and then doing a structural assessment based on what we have determined as the site of injury. So if there's autonomic signs and symptoms associated with this, then we're going to be thinking complex regional pain syndrome. If there are sensory or motor deficits on nerve conduction studies, then we're thinking this is a peripheral nerve injury. If there is root compression on imaging studies, and we have mixed findings on sensory and motor, that is recognizing that if you have root compression proximal to the dorsal root ganglia, your sensory nerve action potentials may look normal. but motor may be impaired. And then is there a cystic cavity on MRI? So looking at the structures that could be contributing to particularly neuropathic pain, and then when possible, treating the cause. Using sympathetic blockade for complex regional pain, looking at functional rehabilitation strategies, providing surgical decompression and detethering as necessary. So then they talk about different set of tiers. The first tier having to do with sympathetic blockade using lidocaine patch for acute consideration of particularly neuropathic pain, and then gabapentin if more chronic, or pregabalin. The second tier then includes, yes, gabapentin and or tricyclic. So you're doing a combination of things, and then the tricyclic antidepressants and or tramadol. The third tier that's when you actually go to pregabalin if the gabapentin didn't work appropriately. Considering opioids, but again, trying to minimize use of opioids as much as possible because of all the side effects associated with that. Consideration of intrathecal medications, including morphine, clonidine, and or baclofen. And then non-pharmacological strategies, including surgical decompression as we go through there. So we recognize that nociceptive input is also going to contribute to spasticity in those folks who may or may not be at risk for autonomic dysreflexia. Nociceptive input from other sources can also contribute to ramping up neuropathic pain, activating those additional modifiers and substrates that we talked through earlier. So as you see increased spasticity in somebody who had been normal, recognize that something is happening below the level of the injury that is contributing to, whether they recognize this as painful or not, is contributing to, this is a noxious stimuli below the level of the injury. So when we talk about pain above the level of the injury, I'm not going to spend too much time on this because Dr. Vivas Alvarado has just gone through a really excellent presentation. But recognizing that nociceptive and neuropathic contributions to pain can occur. And we recognize that the musculoskeletal system is certainly at risk. So is the visceral components as you come through there. But Dr. Vivas Alvarado, from his presentation, but even more importantly from a recent manuscript that he's put together, has also noted the influence of conditioning and weight management, managing upper extremity pain. Surprisingly, there's not a lot of literature that talks about body weight in wheelchair users and the influence of body weight on nociceptive pain and or neuropathic pain. So the bottom line is we're going to manage the musculoskeletal pain and the neuropathic pain above the level of the injury, much as Dr. Vivas Alvarado described just a few weeks ago in his excellent presentation. So again, nociceptive pain above the level of spinal cord injury. This is actually fairly easy because we can identify the source when it's above the level of the spinal cord injury and go specifically after. You know, is this something to do with the myocardium? Is it something to do with the lungs? Is it cholecystitis, etc.? We can treat the underlying cause when we're treating pain as we would with a neurologically intact individual. Similarly, he described issues with neuropathic pain and particularly talked about cubital tunnel syndrome, ulnar compression at Guyon's canal, carpal tunnel syndrome, etc. Interesting, Dr. Felix and I had just put together a paper that is in Press and Topics in Spinal Cord Injury Rehabilitation, comparing or looking at the potential contributions of adipose tissue on neuropathic pain at above or below the level of the injury, recognizing that neurogenic obesity can be a contributing factor to actually accentuate neuropathic pain. So when possible, trying to manage that pain as we have down here, And again, when it's above the level of the injury, you all know how to manage that. It's the same as managing any other musculoskeletal or neuropathic pain that you find in neurologically intact individuals. But as we talk about pain at and below the level of the injury, things get a little bit more tricky. Trying to determine the underlying cause is very, very important, be that nociceptive or neuropathic, as we have listed here. Recognizing that, again, pain below the level of the injury is a noxious stimuli that will cause a massive sympathetic outflow and subsequently an impending hypertensive crisis. We know this is autonomic dysreflexia. And so I can hardly do a presentation without talking about AD. When you have a noxious stimuli below the level of the injury, the afferent information ascends the cord but is blocked at the level of the spinal cord injury, and you get this massive sympathetic outflow that causes splanchnic vasoconstriction and high blood pressure. Increased pressure is sensed by baroreceptors that send information to the medulla, which sends information back to the heart and causes a relative bradycardia. But below the level of the injury, you may remain vasoconstricted. Above the level of the injury, you try to dissipate that pressure with flushing, sweating, and potentially a pounding headache. We recognize as autonomic dysreflexia. Any noxious stimuli below the level of the injury can contribute to autonomic dysreflexia and spasticity in those folks at risk. And so recognizing the acute management of autonomic dysreflexia in these scenarios, we're just trying to keep the person from having a vascular bad outcome, so myocardial infarction or a stroke or something like that. And so we will manage this, but we have to ultimately determine what is the cause, what is the underlying cause of the autonomic dysreflexia, and we have to manage that pain. Yes, it's a noxious stimuli below the level of the injury. So when it's below the level of a spinal cord injury and the person doesn't have sensation, we recognize that we're going to have to go on a fishing expedition. And so this is going to require additional imaging. This is going to require us to be thinking outside of the box. What could be contributing to this person's autonomic dysreflexia spasticity? That is, there is some pain below the level of the injury, and we have to figure out what it is. And so the fishing expedition begins, recognizing that we have to figure out what this is, or the person is going to be at continued risk for autonomic dysreflexia, hypertensive crisis, stroke out and die, which is suboptimal. Recognizing that also you can have neuropathic pain, not just nociceptive etiology below the level of the injury. So certainly radicular, so with regard to specific root levels. Folks with spinal cord injury can still get lumbar stenosis. They can still get lumbar radiculopathies, and they can still get complex regional pain syndrome below the level of their spinal cord injury. So it's important for us to keep this in mind as we're doing our fishing expedition. How do you manage this pain? Most importantly is to identify the pathology. Treat the underlying cause. Again, a sympathetic block may be necessary. If it's related to or ramped up by neurogenic obesity, weight loss is going to be an important part of this, and not just any weight loss, but adipose tissue loss. And then we consider our pharmacological options. Once we've treated the underlying cause to the extent that we can, consider using our tricyclic antidepressants, our anticonvulsants, and or combinations. Consider both intravenous as well as intrathecal if the oral medications didn't do it. And if things persist despite what we feel are optional treatment, then look on to surgical consultation for potential surgical decompression dorsal column stimulators. So these treatment options have been discussed for some time. I'm actually going to talk through in a little bit more detail with regard to the tier 1s, the tier 2s, and the tier 3s. Again, when it's Neuropathic pain, typically we're going to be thinking about sympathetic blockade as our go-to. That's our first consideration, lidocaine patch in the acute setting and gabapentin in the chronic setting. If those options haven't satisfied us and the person continues to have significant problems, we consider a second tier, including tricyclics or tramadol, and combining gabapentin and a tricyclic antidepressant. Then we move on to the third tier. If the person is still experiencing significant pain and or symptoms, that is autonomic dysreflexia and spasticity, consider pregabalin, consider opioids, intrathecal morphine, clonidine, baclofen, and then non-pharmacological strategies as we move forward with this. Now, opioid alternatives, because our society is having such huge problems, and this occurred as I was finishing my residency. My first job out was in Kentucky, and Kentucky had a massive epidemic of opioid deaths back in the mid-90s associated with the use of opioids, the inappropriate use of opioids. So I was kind of sensitized to that from the get-go. In recent years, and by recent I mean within the past 5 years or so, we have especially looked at alternatives to using opioids to manage pain, and particularly non-nociceptive pain. So don't choose opioids or narcotics as the first choice for treating neuropathic pain. We know that they're a leading cause of addiction and avoidable death, and there are many effective and safer options for managing neuropathic pain. I'm going to spend just a few minutes talking about marijuana, cannabis in treatment of spinal cord injury pain. There's not a lot of literature on this. I'll share with you of the more recent manuscripts that have come out, which ones appear to be providing us the best information. Now, just as a reminder, marijuana, cannabis basically has two major components. There's the psychoactive tetrahydrocannabinol, or THC, and there are two main types for this. And again, this is going to influence a person's sensory perception of things. But then there's the non-psychoactive CBD, cannabinoid receptors. And this is the component that may also have an anti-inflammatory component to it, which inhibits the arachidonic acid conversion by cyclooxygenase. So 3 studies of note. Hawley in 2018 reported out the use of cannabis in just 27 individuals. Again, we were just starting to take a look at these things. 2/3 of these folks had used cannabis previously, but the group in general was using mostly to manage spasticity. And I mean, I had patients report this to me, again, way back in the 90s, back when I was a resident. I had folks who had stopped using baclofen, stopped using other options because they were simply managing their spasticity with marijuana. California at the time was a little wild, but not quite at that point where it was legal. Nonetheless, when it has been legalized, a number of individuals have also reported using it for recreation as well as sleep and pain management. Anderson in 2017, this is a study out of Denmark, looked at over 500 individuals with spinal cord injury and found that of those who were using cannabis, almost 80% had previously used it. And now they were reporting its use for recreation and pleasure, so about 80%. And then a number of them were also reporting its use for spasticity and pain management. Wilsey had an interesting manuscript came out in 2016 where they actually did a crossover randomized controlled trial with vaporized cannabis versus vaporized placebo to look at its effect on neuropathic pain after spinal cord injury. So they had 42 individuals who looked, and what they did is they actually looked at 3 conditions. One condition was the placebo. One condition was a relatively low So it was about a 3% concentration of the vaporized cannabis, and then a 6.7%. They called those the placebo, the low, and the high dose as they came through there. And they found a drop in the visual analog score of about 0.5 for folks who responded to the placebo. Those on low dose reported a 1.5 improvement in the visual analog pain score, and those at the higher concentrations reported 2 points in change on the visual analog scale. So, so overall, there was a 30% reduction in pain reported by these 42 individuals. Interestingly, the placebo group reported 45% improvement. The low concentration group showed a 70% improvement, and the high concentration 88% improvement. So there are additional management options to us. I know that in the United States, and particularly in Florida, there are grants, or I should say grant competitions underway right now looking at the use of cannabis, marijuana, particularly for folks with spinal cord injury. I think it's important to consider the non-pharmacological treatment strategies that we have for our folks with spinal cord injury, recognizing that sleep, positioning, acupuncture, massage, TENS, all of those can contribute. Recognize the additional benefits of diet and exercise, which surprisingly have not really been looked at much in the spinal cord injury population, although we are recognizing there seems to be some relationship. We recognize also in spinal cord injury, they have a higher percentage of sleep disorders than does the non-spinal cord injured population. And part of this is attributed to the spinal cord injury and the neurological effects that contribute to sleep apnea, but as well, the fact that up to 94% may have neurogenic obesity, and the fact that obesity significantly contributes to sleep disorders as well. There's kind of a double whammy. And so I'm just, you know how I harp on this, but I just want to bring us back to what are other non-pharmacological strategies that we can have. Is there a reason to keep folks' adipose tissue down? And I would say yes, absolutely. And we know that there are contributing factors to ramping up pain, particularly neuropathic pain, but also nociceptive pain, pain in the joints when somebody is carrying around more weight. That makes it more difficult to do wheelchair propulsion, wheelchair transfers, pressure relief, etc. Psychological treatment of pain can include cognitive behavioral therapy, behavioral activation and relaxation techniques, and in some cases, hypnosis. I think this is an area that we, as PM&R physicians, should be more involved in, and we should be getting our neuropsychologists more involved in our management strategies for our folks with spinal cord injury. I think that sometimes we forget the collaborative nature of what we do, particularly in the outpatient setting. And then obviously there are interventional and surgical strategies. And so if we're not making appropriate referrals to our interventional spine folks, we should be taking a look at that as well. So recognize that pain is something that all of us experience in our lifetime, but folks with spinal cord injury are particularly at risk for a number of reasons. I think it's important for all of us to keep in mind that we might minimize someone's pain or their expression of pain because we really don't have a good objective standard of what pain is. And sometimes we're limited by our own personal experiences of pain in our feelings of compassion for others. And so this amazing academician, Spencer Dryden, who was the drummer for Jefferson Airplane way back in the day, did have this interesting, this is one of his lyrics: "We no other pains endure than those that we ourselves procure." And so I think that we need to look beyond our own personal experiences with pain. And particularly, again, keep in mind that, that we are in an interdisciplinary specialty, and we really need to bring in our colleagues from a number of different disciplines, our therapy colleagues, our psychology colleagues, our social workers, our recreational therapists, as well as our medical colleagues, as we look at how to manage pain in persons with spinal cord injury. So again, Dr. Vivas Alvarado had recently done a great presentation. I didn't go into a lot of the things that he discussed because I didn't want it to feel redundant, but I'm open for questions, thoughts, concerns as we move forward. You can either do those in chat or ideally just take yourself off mute and let's have a discussion. Thank you for staying with me.
I'll talk. This is Dr. Felix. Let me see if I can get my video on. There we go.
Is this Dr. Felix?
Yes.
I can barely hear you.
Oh, no. Okay.
That's better.
Okay. All right. Better?
Yes.
So thank you for that excellent presentation, Dr. Gator. I just wanted to make a few comments, just things that I was thinking of while you were speaking. I think one of the things that is interesting to me, or one of the things that's interesting to me that's sort of unique to the SCI patient population, but not necessarily, is that when we are looking at a person who has a spinal cord injury, oftentimes they have lots of different kinds of pain. So when we're talking about treating pains or managing pains, it's not just one type of pain. And so you have to have those considerations in mind, that you have upper extremity, nociceptive shoulder pain combined with, leg pain that is probably due to neuropathic mechanisms. So it's interesting for me to study and to figure out how to study different pains within a single individual, and how different mechanisms may be contributing, and different treatment methods may differentially affect their pains. So it's complicated. And the other thing I wanted to mention is, particularly for me, most of the work that I've done has been in really chronic neuropathic pain. And I think you made really good points about alternative sort of non-pharmacologic treatments. When we're studying people with chronic neuropathic pain, it's because nothing has worked, and that's why they're still chronic. And that typically the most important thing to them at that point is not necessarily eliminating their pain, because they've tried everything, but it is how they can function physically and psychologically, emotionally, when they're dealing with this kind of a chronic persistent pain, so that those non-pharmacologic, sort of more psychologic driven types of treatments or interventions may be the most effective in helping them live the life that they want to.
Excellent.
So that was all.
And I just wanted to give Dr. Felix a shout out. She's actually got several different trials going at the moment, looking at pain in spinal cord injury. The SCIP project is actually a multi-center trial that she has going. And she's worked with several of the investigators here, looking at both upper extremity pain, but as well managing neuropathic pain with TENS. I mean, so again, I think sometimes we forget our resources, and I just, if the residents haven't had a chance to work with her in that regard, keep in mind that she is a pain specialist, particularly with regard to research, and so we're grateful to have her with us as well. There was one other point you made, and I just lost it, but I wanted to speak to it. Oh yeah, the chronicity of pain. Those of us who have lived a few years longer than the rest of you are experiencing pain in our daily lives. And as we age, that's the nature of the beast. We see spondylitic changes, we see a number of things happening, changes in our body composition, et cetera, that make us at higher risk for pain. Our folks with spinal cord injuries seem to have an accelerated rate of aging. And so I wanted you to keep that in mind, because they have a number of reasons to experience more pain than you or I might experience as we're going through this. So there's a question about how do you discuss pain management when they're interested in marijuana? Again, I'll go back to my residency days in California when it was illegal. Now it is legal, at least medical marijuana, but they have dispensary systems, and you have to go through a process. You know, I'm not sure if we have a physician within PM&R who is listed as being able to prescribe marijuana, and particularly with regard to the dispensaries. Where I came from in Pennsylvania, you had to go through a process in addition to your licensing to be able to do that, and I believe that's the case here as well. But the bottom line is, how do you go about the discussion? And I think that to have the discussion, you need to talk to them about their pain and their expectations. You need to see what has been trialed for which type of pains previously. You need to see what their lifestyle includes now, and you need to see what their expectations of cannabis or CBD, what that is, and why they think this is going to be an answer to them. I think, you know, I would like to be able to say there's a lot of research out there showing that the use of either THC or CBD has improved spasticity, but there's not, surprisingly. And so there's a study that we need to do, Liz. I'll look right to you. And similarly, there's very limited information about managing neuropathic pain. And so I think that part of what we have to tell them is that it may be good, and we don't know for sure. Within the confines of our medical legal system, we can make recommendations to trial it, and then, as I would with any other intervention, come back and let's see how it's doing for you. Are there side effects associated with it or not? But I think again, even before I have the marijuana discussion, I like to have the discussion, especially with a new patient who may have a chronic pain, of, you know, what are your expectations? Because if you think that I'm going to magically take away your pain, I'm going to disappoint you, and I'm sorry, I'll just say that up front. However, if you'll work with me, I think that we can improve your functional abilities within the limit of your pain, and that's kind of our starting point to have the discussion about pain management. I think any of us would like to have pain eliminated, and yet those of you who've managed with chronic pain and are going into pain management, you know that it's really hard to take pain away completely. And so managing expectations, again, I'll kind of leave it at this, is perhaps one of the most important things that we can do with our patients, and just help them to understand what are the realistic expectations, and how we will help them with their functional abilities within the limits of their pain. That was a long answer to a short question. All right. Well, again, I thank you all for your, at least you appear to be awake as far as I can see on the screen. So thank you for your attention. Everybody have a great day, and I'll be back. Or even if you may be falling asleep, I get that, sorry. Bye-bye.